Good morning. Thank you, Godfather, for the invitation. Appreciate you. I mean it. I really do. I think I went all the way very quickly. So sorry about that. There you go. So I have no financial, unlike this guy, sadly. But I do both approaches. And I think you need to know a little bit of your history. And I am old enough to know Dr. Porter when he was alive back in Oregon. And he wrote in 1996, I conclude the results of primary angioplasty of the SFA and popliteal artery are so dismal that they should not be embraced as a viable treatment alternative by vascular surgeons. That's where we were in 1996 when I started my residency. And J.F. Kennedy said those who are dare to fail will achieve greatly. And I think a testament to 2023 first-line endovascular approach to fem-pop disease is the norm in claudicants as well as CLTIs with good tibial runoffs. Surgical approach, I think, is still being used for common femoral or in good risk patients with large burden of disease or endovascular failure maybe. And yet both approaches share a common fate, and the common fate is what will be the theme of the session today, which is failure. And Dr. McKinsley excellently gave us the biological background behind why things fail and why DCB has such a huge impact in patency. And this is just a paper recently published that gives you a little bit for claudicators. What is the index limb amputation rate when you operate and intervene on a POP? It's 7.5% at 4 years. I submit to you that natural history of a claudicator is less than 4% limb loss over the lifetime. SFA segment PVI 3.4%, and when you intervene on both, you have a 5.5 index limb amputation at 4 years' time. But again, I submit to you that's a little bit too high. Now, we're talking about TLRs, we're talking about recurrent disease, and when you intervene on both, you have a 18%. So we're still ways to go to do the right job, as Kumar was saying, do the right job at the beginning. Nevertheless, if we do this for a living, we will see this, and this is a very apropos. And these are all the recurrent risk factors what we learn over the times when things happen. And this happens just not on endoluminal therapy, but also on bypass. And we have great documentation in the surgical literature how our bypasses also fail over time as well. So how do I choose my approach? I go through the clinical presentation and indications what I'm doing. I evaluate the risk of the patient. I go through the prior intervention data in terms of the type of procedure, the interval of the procedure, the presentation, and the current arterial anatomy. And out of using all those things, we come to a decision. So when do I intervene in asymptomatic presentations? I think I intervene only for primary assisted patency. So restenosis, not occlusions, regardless of the type of indication on the prior revascularization. And the approach of choice for asymptomatic reinterventions is usually endovascular in my practice. And these are detected by ultrasounds, of course, surveillance ultrasounds. Now, when patients present with intermittent claudications, I think I state my point that prior intervention is occluded, medical management is first. If the prior intervention has a symptomatic restenosis, that's a technically feasible procedure. I think you intervene again under the auspices of primary assisted intervention with symptoms. And again, the approach of choice is usually redo endovascular, as Kumar just went over, and Dr. McKinsey as well. Now, for CLTI, I think you must reintervene if the patient is a limb salvage candidate, and I think the surgical, the decision-making is actually a complex one that involves all these things that we talked about before. So when a patient is a high risk in CLTI presentation for redo or recurrent femoral popliteal disease, tend to bias the approach to endo approach. And if the patient is an average risk and you have a single segment greater saphenous vein, I think certainly bypass surgery should be considered. Other considerations, prior interventional data, whether the patient had an open procedure or endo procedure, I think that's going to bias you a little bit. Although redo bypass can be done, we tend to go after a failed bypass to an endo intervention. If you left scaffold versus no scaffold also may bias you a little bit in the complexity of the case itself. What is the progression of the clinical disease? Do they actually started with the claudication, now they are critical limb ischemia? We all seen that as well. And that may bias you towards, large tissue loss, Dr. McKinley said, maybe a bypass option early on instead of trying to redo endo if you have a lot of perfusion needs. The wound trajectory status, sometimes the patients are going stagnant, their wounds, and they have an occlusion is different from patient that is already almost healed up. Maybe you need a little bit push on wound care, and that's it, even if the intervention is actually failed from the hemodynamic perspective. Maybe clinically the patient is almost there to heal, and wound care therapy will do the job for you. So compare the status of the previous outflow to the new outflow. Maybe there was a 3-vessel runoff for claudication. Now when you see it as a single-vessel runoff, is that going to influence your decision? And it should. The timing of the failure, as Kumar said, I'm good but not that good, and when things go easy, maybe there's a thrombotic burden there, and that's exactly what happens sometimes. And the lesion characteristics as well. So a couple of cases very quickly. 73-year-old, CLTI, a lot of risk factors, as you can see there. A common femoral endarterectomy 4 years ago, and present for rest pain back then. He presents with CLI tissue loss on the 5th. And you can see there that up and over, the common femoral is occluded. The profunda is actually reconstituted, but there's no origin disease. A little bit of a tibial runoff compromise. So what we select to do is first evaluate if he's a candidate for therapy, and in this case he was. He's certainly a high-risk patient. A prior intervention was an open fail intervention. So for us, the approach was an endo intervention to prevent a redo groin, a very high-risk patient, and we end up doing a common femoral artery stenting and an outflow PTA for his tibial. Another case, very quickly, 72-year-old, again, referred for gangrene after a second and third toe amputation. Typical risk factors, a prior SFA atherectomy and stenting 2 months ago for the same indication. And this is an AMP site that actually turned to gangrene. So again, the recurrent presentation, the algorithm is CLTI. I think you must revascularize CLTI patients when they show with failed FEMPOP interventions in the past. This patient was an average risk patient. It was an occluded stent, and I had the same experience as Kumar. It was an easy cross. We used an EPI aspiration thrombectomy and then a DCB. And you have the pictures there to show it. So in summary, I do not re-intervene if patients present with asymptomatic occlusions of prior interventions. I do not re-intervene if patient presents with intermediate claudications and occlusions of prior interventions. I think that should be a medical treatment first. Redo endo approach in patients presented with asymptomatic but are picked up by surveillance, either endo intervention or bypass stenosis. I think you should maintain the primary assisted patency. If they present with intermediate claudications, only with the severe claudications and the average risk after failed medical therapy. And if they present with CLTI, average risk when single segment is not available, an endo approach is certainly something to consider. I choose a surgical approach after failed endo first when patients present asymptomatic, never. If the patient presents with intermediate claudication in the average risk after failed medical therapy and multiple failed interventions, I think we throw the number of three and you're up. I think that's a reasonable thing. And then I choose in patients who have presentation with CLTI, they are average risk, and there's a single segment greater saphenous vein available. Thank you very much for your attention.